We've got one final speaker today, and I'd like to invite Nabila Chowdhury. She's from the University of New South Wales, this time you really are, and you're going to be talking a bit of a slight shift, the relationship between psychosis and offending in New South Wales from two population-based data linkage studies.
So I'll be pressing this one. Good afternoon, everyone. I'm Nabila Chowdhury from Justice Health Research Program, School of Population Health, UNSW. Today, I'm talking about our project, Psychosis and Offending Behavior in New South Wales. I'd like to begin by acknowledging the traditional owners of the land on which we are meeting today. I pay my respect to the elders, past and present. I'd also like to, it's not working. Yep. It's not working. Sorry. I'd also like to acknowledge the following individuals for their valuable contribution in this project. Throughout this presentation, I'll talk about the first data linkage study, the Psychosis and Offending Data Linkage Study, which was started in year 2016, followed by the updated data linkage study, which is currently going on, and I'll share some of our future analysis plan. So talking about psychosis, it is a chronic mental illness which is often considered to be a risk factor for criminal offending, including violent offenses. Previous studies from all over the world has shown significant association between severe mental illnesses and offending, and studies also shown higher prevalence of any sort of mental illness in the prisoner populations compared to the general population, and this is similar in Australian prisoner population. So in our first data linkage study, we basically compared the offending behavior of all the individuals in New South Wales who were diagnosed with psychosis from the year 2001 to 2012 with the offending behaviors of their matched controls. Those matched controls who were never been diagnosed with psychosis in the same time period. So we found that individuals with psychosis were 5 times more likely to offend compared to their controls, although their offending pattern were very similar. 10% of all offenses in New South Wales were committed by the individuals with psychosis from between 2001 to 2015. In a sub-analysis, we followed the individuals with psychosis who appeared on the court and who had a prior diagnosis of psychosis. We found that only 26% of those individuals received a treatment order. That is, they were diverted into Section 32 and Section 33 under the Mental Health Act. Treatment orders were 50% lower in the Aboriginal individuals. And we also followed these individuals for their reoffending behavior, and we found out that reoffending were 12% lower in those with psychosis who received a treatment order compared to those who received a punitive sanction, that is fine, bonds, etc. And then we looked into the community mental health treatment contacts after their first offenses. So we found out that those individuals who contacted with the community mental health services pretty early, that is within the 30 days of their first offense, the reoffending rate were lower in this group. And also the increased number of community mental health service contacts significantly reduced the reoffending behavior in this group. Yeah, sorry, I was not changing the slides. I apologize. So these images are from our core diversion paper. So the first image, that is the Kaplan-Meier curves, it is showing that those individuals who had a prior diagnosis of psychosis and who got the treatment order in the court, they took more time to reoffend compared to those who received a punitive sanction. And the results from this table is showing that for both the groups, that is the treatment group and the punitive sanction groups, those who had no contact with the community mental health services after their first offense, they were more likely to reoffend. And the number of, as I said before, the number of increased number of community mental health services were significantly associated with reoffending behavior. So for this updated data linkage study, we received 6 new data collections from 6 new data collections. Overall, we have all these 14 data collections, which are New South Wales Health and New South Wales Hospital data collection, Emergency Department data collections, Mental Health Ambulatory data collections, New South Wales Boxers reoffending database, and deaths data. And also in the new databases, we have New South Wales Mental Health Review Tribunal database, controlled drugs data collections, and 4 data collections from New South Wales Department of Communities and Justice. And these are housing database, child protection database, and out-of-home care database. This diagram is showing the overall linkage of all the data collections we have with our cases and controls. The linkage was done by New South Wales Centre for Health Record Linkage. So we got our cases, that is individuals with a diagnosis of psychosis, from the 2 data collections, that is New South Wales admitted patients data collection and New South Wales Emergency Department data collections. And for each case, 2 age and sex matched controls who had never been diagnosed with psychosis were selected from the Center for Health Record Linkage master linkage key. For this study, we grouped our psychosis cases into 3 groups that were based on the ICD-9 and ICD-10 codes. These are schizophrenia and related psychosis, affective psychosis, and drug-induced psychosis. So 55% of our study population were men, and the prevalence of being aboriginal were higher in the individuals of psychosis compared to their controls, and cases were more likely to be from a disadvantaged area of living compared to their controls. So we looked into the most recent diagnosis of our cases and in each year. So from this diagram, we can say that if we look at the green line, we can say that if you look at the second last bar, we can say that 11.5% of all individuals with psychosis, their most recent diagnosis was in 2019. Year 2019. The reason behind doing this diagram is to find out those individuals those individuals inside the prison who had their most recent diagnosis, so that we can say that these individuals need more treatment in prison. So overall, according to the updated data, the results were pretty similar with the past data linkage study. So overall, we got that our individuals with psychosis were almost 5 times more likely to offend compared to their controls. And as I said before, their offending pattern were very similar, similar between the cases and controls. Overall, we got 10.4% of individuals with psychosis were incarcerated at least once between the year 2001 to 2020 compared to 1% of controls, and the prevalence of being an aboriginal was higher in cases compared to the controls. And among the cases, 18.6% had their most recent prison episode in the year 2019 to 2020. So we did the recency of diagnosis before in the bar chart. I have shown that. So here we with the help of that analysis, we could estimate that 991 individuals with psychosis of our study cases had their most recent diagnosis of psychosis in year 2019 to 20, and also they had their most recent prison episode in the same year. So we can say that these individuals need the treatment most inside the prison. A further 239 individuals were diagnosed in 2017 to 2018, and 455 individuals in the year 2018 to 2019. So, considering the total prisoner population of New South Wales in the year 2019, we could estimate that somewhere between 5% and 8.8% of the total prisoner population were in the prison in year 2019, and they were also diagnosed with psychosis very recently. We also have the excess of prison self-harm database. So overall, the individuals with psychosis, 15% of the individuals with psychosis who went to the prison in these years self-harm inside prison compared to 3.6% of controls. Yeah. And then we looked into the factors which were associated with the self-harm behavior inside the prison in our study population, and we found out that yes, individuals with psychosis were more likely to self-harm inside the prison, and we also found out that females were more likely to self-harm compared to the male prisoners. Younger individuals were more likely to self-harm, And Aboriginal individuals were more likely to self-harm inside the prison. We also used prison alert database in our study population. So about 11,344 individuals with psychosis who had a prior diagnosis of psychosis before entering the prison between year 2001 to 2020 were selected for this analysis. So we got that only 18.2% of individuals with psychosis got a prison alert and out of these, 70.1% of alerts were given on the mandatory alerts. They were the mandatory alerts, that is, they were given for the self-harm alerts. So this bar chart is showing the percentages of percentages of cases and controls who were given alert or not. So in cases, 18.2% of cases were given an alert. So among these individuals, 11.8% actually self-harm. And 6.1% of cases who among those who were never been given an alert self-harmed. So from this bar chart, we can say that prison alert systems are good, are beneficial in predicting the future self-harm, but although the number of alerts are really low. Corrective Service New South Wales run a series of in-prison programs, which includes EQUIP's Foundation Program, Aggression Program, Addiction Program, Domestic Violence Program, Intensive Drug and Alcohol Treatment Programs, Sex Offender Treatment Programs, Violent Offender Treatment Programs, and Education Programs. 19.5% of individuals with psychosis either commenced or completed at least one of these programs compared to 17.1% of controls. The prevalence of, in both cases and controls, the prevalence of commencing any of these programs were higher compared to the prevalence of completing any of these programs. Later, we found out that prison programs has no effect on the reoffending behavior of these individuals. So we followed, we followed the individuals who were diagnosed with psychosis from year 2001 to 2018 and who went to prison and also released from prison in that period. We then followed these individuals for their reoffending behavior until June 2020. The median follow-up time was 4.5 years. And we found out that almost 70% of individuals with cases reoffended compared to 59.5% of controls. We also looked into the factors associated with the reoffending behavior in this group, and we found out that gender has no effect in reoffending behavior in this group. Aboriginal individuals, younger individuals, individuals with single marital status were more likely to reoffend in the post-release period. We also found out that the in-prison factors, that is multiple prior prison episodes, prison alerts, and prison self-harm incident were associated with reoffending behavior. They were so those who self-harm inside prison or received a prison alert, or those who have multiple prior prison episodes, and those who had a prison episode which lasts more than 6 months, they were more likely to reoffend in the post-release period. So next we try to find out the factors associated with the post-release contact with community mental health services. We found out that so we received the housing database from New South Wales Department of Communities and Justice. So we found out that so I'll jump to the So we found out that the individuals in our study population who were housed, who had the housing support by the social housing, who were housed by the social housing support, and who were in the waiting list, and also who were housed by other providers, where they were more likely to contact with community mental health services in the post-release period compared to those who has no housing record in the database. So we assume that these individuals who has no records in the housing database, maybe they don't have any housing support. So we also looked into the other factors and found out that males were less likely to contact with community mental health services in the post-release period compared to the females, and younger individuals were less likely to contact with community mental health services, and those who had a single marital status during the time of their most recent psychosis diagnosis, they were less likely, they were more likely to contact with community mental health services. And those individuals who got a prison alert during their most recent prison episode, they were more likely to contact with the community mental health services. Finally, we looked into the mortality in our cohort, and we found out that 22.6% of individuals with psychosis died between year 2001 to 2019 compared to 11.5% of controls. We divided our cases and controls into 4 groups, considering their imprisonment history. So we got like 4 groups, cases with or without the imprisonment history, and controls with and without imprisonment history. And here our reference group was controls without an imprisonment history. So we found out that cases with or without imprisonment history were more likely to die compared to the controls who has no imprisonment history. And also we found out that controls with an imprisonment history were less likely to die compared to the controls who had no imprisonment history. We also looked into the deaths inside the prison. So there were 38 deaths inside the prison in between 2001 and 2019, and 37 of them were in the individuals with psychosis. And out of all these deaths, 17 deaths were due to suicide. And among these 17 individuals, 6 individuals were given an alert, and prison alert, and 3 individuals actually did self-harm before committing the suicide. So in conclusion, we suggest that, we assume that the community mental health services are beneficial in reducing the reoffending behavior, and prison alert systems are really beneficial for predicting the future self-harm incident, although the prevalence of getting a prison alert is very low. And also, prison programs do not have any effect on the reoffending behavior, and stable housing appears to improve the access to mental health services among the study population. So in future, we want to explore the prison movements data and prison intake screening questionnaire database. We also want to investigate the New South Wales controls drugs and addiction drugs data collections and child protection and out of home care databases. We are in the process of requesting the pharmaceuticals benefits scheme database and Medicare benefits scheme scheduled claims data. So we would like to investigate these two data collections, and we are currently investigating the mental health review tribunal orders data collections for our study population. So that was all from my side. So thank you.
There's a lot to unpack there. Any questions before we break for the end of the day and for a drink?
I feel guilty about asking a question when it's the end of the day. One thing, I apologise, I may have missed the slide that clarified it. You said that the programs in prison have no effect on reoffending. Was that for the population with psychosis or for the entire population in the study?
So it was for our study population, that is the individuals with psychosis and their matched controls.
Thank you very much.
Yep. Thank you.
Any more questions? Last chance. Yes?
So based on the type of crimes that your population was being arrested for, so public order offences mostly, and probably resisting arrest and sort of acts intended to cause harm, it seems like they were just having a psychotic episode in public and got arrested, and instead of being diverted into treatment or something therapeutic, they just get put in prison. And then based on the number of alerts and self-harm, they're the ones who are actually causing a lot of the additional workload of people in the corrective system, probably because they shouldn't be there. So what's the public policy solution, or where do you see this evidence making a difference maybe earlier, or not in the context of corrections? Because it's pretty clear from what you've presented that these people they're not benefiting from being in prison. The longer they spend in there, the more likely they are to reoffend and to self-harm and to die. So what's the solution? Where can we channel more funds or resources to put them in a place where they're going to get better instead of, self-harming, dying and reoffending?
Yes, so as I showed that prison alerts really worked in predicting suicide and everything, but I say that the number of getting alerts are really low. So one possible solution could be to strengthen that alert system in the prison, and also to allow the individuals with psychosis to get more community mental health treatments, so that they stay away from the criminal justice system. Yeah.
Thanks for the walk. Following on from that question just then, looking at the suicide rate in prison, which is higher for your cohort population, But then in an earlier slide, you mentioned that people who weren't imprisoned and were in your cohort had a higher death rate than people who were not in your cohort. So is that correct? That's what you said, I think. So
Can you repeat it, please?
yes.
again?
So you were saying that of your cohort where there was no imprisonment, they had a higher death rate, and you didn't specify whether that was suicide or other deaths, than if they had been in jail, whereas in jail the death rate was higher than your control group through suicide. So basically you made those two statements. So it's almost like you're damned if you do and you're damned if you don't. So you either you don't go to jail, but then you have no mental health services to pick you up and to help you, or you go to jail where you're more likely to die from suicide because the mental health services within the jail are not adequate either. Is that what I'm taking away?
In my last slide, can I go back? So basically, we showed that prisons are not a good place for individuals with psychosis, of course. They were more likely to so overall cases were more likely to die compared to the controls in the whole study period, regardless of they're in prison or not. But in prison, individuals with psychosis, yes, the suicide rate were high. But the control groups who are in prison, they are less likely to die compared to the control group who are not in the prison. So maybe we can say that prison is a good place. I don't know. I mean, maybe it's good. It's good place for the control groups, but not for the cases. Of course, yeah.
Yeah.
Did I answer it correctly, or I'm not getting your question?
It's not a good place for either. That doesn't injure. The other one I was also a bit curious, why did you include the drug-induced psychosis, which are kind of more situational or contextual cases rather than someone who has a psychosis due to schizophrenia or another severe psychiatric illness, which can't be cured, really can only be maintained?
Drug-induced psychosis were included in the study with the suggestion of a group of psychiatrists in this study.
Okay.
So yes, but they so in our previous data linkage study, we showed that these individuals are more likely to reoffend compared to those who were diagnosed with schizophrenia. So these individuals, they are more likely to come across with the criminal justice system.
Yeah, but possibly because they've got different responsivity and needs. Different needs and should have been.
Also, studies also showed that those individuals who were diagnosed with drug-induced psychosis later on in their life, they are diagnosed with schizophrenia. Yeah.
Okay, well, thank you very much.
Thank you.
Very interesting. And now I'd just like to invite everyone to join us for a drink.